Hello everyone and welcome back to my channel. So today we'll be doing the chapter of breast. Now this chapter has an overlap with surgery. ठीक है, तो बाकी के points आपको वहाँ से देखना है. Pathology perspective से I'm going to talk about this chapter in detail, and there are very important differences between different entities that I'm going to highlight here. So without further ado, let's dive straight into Robbins. Now, starting with the benign lesions, here you have a chart, a very important chart, which will tell you about the epithelial breast lesions and the risk of developing the invasive carcinoma. Now, there are four classifications of lesions which have different risk, for development of invasive carcinoma. So this is a very important chart. एग्जाम में इसके ऊपर सवाल आते हैं, शॉर्ट नोट्स आते हैं, क्वेश्चंस आते हैं. आपको ये चार्ट लिखना है और उसके साथ आपको ये सारे एंटिटीज को थोड़ा बहुत एक्सप्लेन भी करना है. These are basically the epithelial lesions which have the risk of developing to invasive carcinoma. And if you see that, number one is the non-proliferative breast changes, and these have very minimal risk. They are non-proliferative. I will talk about these lesions, but let me first clarify the basis of this. Number two is a proliferative lesion without atypia. So this is proliferative, but they have little risk, obviously more than the non-proliferative lesions, but then these diseases have got a little bit increased risk. But if it is a proliferative disease with atypia, very important, then the risk is 4 to 5%. And obviously carcinoma in situ will always have a higher risk of getting converted into invasive carcinoma. Now here you must understand there is something called as the usual ductal hyperplasia, and there is something called as the atypical ductal hyperplasia. Okay, now this atypical ductal hyperplasia is the one which has higher risk of getting converted into ductal carcinoma in situ and further into invasive carcinoma. So you must understand the sequence will go like this: atypical ductal hyperplasia to carcinoma in situ, and then to invasive carcinoma, right? And but the usual ductal hyperplasia is something which has got very minimal risk or no risk of getting converted into carcinoma. So what I'm trying to explain here is that if you see a proliferative disease with atypia, here you can see this atypical ductal hyperplasia or atypical lobular hyperplasia. So these are the only two lesions which have a high risk of getting converted into carcinoma in situ. This is the atypical ones. But the usual ductal hyperplasia is something which is basically the moderate hyperplasia or florid hyperplasia, which does not have that increased risk. They are without atypia. Now you must understand this atypical ductal hyperplasia is getting converted into what I said just now. It is carcinoma in situ, right? And you must know that atypical ductal hyperplasia will get converted into DCIS, right? Because it is ductal, so it will get converted into DCIS or ductal carcinoma in situ. And if it is an atypical lobular hyperplasia, this will get converted into LCIS or lobular carcinoma in situ. Okay, I hope you're able to understand. The point I'm trying to make here is that if you talk about atypical ductal hyperplasia, that will get converted into DCIS, and if it is atypical lobular hyperplasia, that will get converted into LCIS, and both of these will ultimately get converted into invasive carcinoma, right? Now the question arises, what is the difference between this ADH and DCIS? What is the difference? And that is where the question lies कि इन दोनों के बीच में difference कैसे करेंगे? क्योंकि in the microscopy, if I show you, you will understand. See, this is the atypical ductal hyperplasia. What you can see here is that a duct which is filled with a mixed population of cells consisting of columnar cells at the periphery. Here you can see this layer. I hope you can understand, this you can see this layer, which is the columnar layer at the periphery, and the rounded cells in the central portion, isn't it? All the cells are rounded, and you can see that there are some spaces which are round and the peripheral spaces are irregular and slit like. So these are basically slit like, peripheral slit like, spaces you can see here. So this kind of an appearance is basically atypical ductal hyperplasia, and these features are kind of highly atypical, but they fall short of diagnosis of DCIS. By this you can't diagnose DCIS. So DCIS आप यहाँ पर देख सकते हो. This is the lobular variety, means this is the atypical lobular hyperplasia, and you know that in the lobular carcinoma or wherever you find the word lobular, ठीक है, ये भी एक concept है जो मैं बता देती हूँ यहीं पर, that wherever you find the word lobular, you must know that the cells here will always be discohesive. ठीक है। लोब्यूलर में सेल्स जो है दे विल बी सेपरेटेड, and ductal में cells will be kind of at one place only. Just now I have shown you the picture. So lobular में cells will be separated. क्यों? Because there is a loss of E-cadherin, right? And you know that E-cadherin is a protein which is encoded by the gene which is CDH1 gene, and because there is mutation of this gene, there is a loss of E-cadherin. E-cadherin basically helps to keep the cells together, right? But when there's loss of E-cadherin, then these cells will be separated from each other, and therefore you have this discohesive pattern, which is basically significant and typical of the lobular variety. So here you can see in this image that these cells are separated, right? You can see these cells are separated and these cells are away from each other. They are loosely cohesive, and this is something which is not found in this atypical ductal hyperplasia. So just by the morphology you can see the difference. Now the question still remains the same, that what is the difference between this atypical ductal hyperplasia and ductal carcinoma in situ? So the difference is basically based on the size and the space occupied. This is the only answer that I can give you, that the atypical ductal hyperplasia or the ADH is differentiated from this low grade ductal carcinoma in situ by size, means it has to be less than equal to 2 millimeter, and the space occupied by these cells has to be less than equal to 2 spaces or only portion of the involved space. So if it is more than 2 spaces and the size is more than 2 millimeter, then it is going to be a DCIS. This is basically the criteria which differentiates both of them, right? Now you must understand that this is differentiated from the low grade DCIS, not the high grade one. High grade one will not have any kind of a criteria like this. It will always be high grade. But if you talk about the low grade one, then yes, it is differentiated by these two criteria, right? And now if you come to this image, I'll be showing you the image of DCIS just to compare and tell you that yes. So here you can see this is the image of the DCIS, right? This is the cribriform variety of a DCIS. You can see that the round, regular, cookie cutter spaces containing calcifying secretory material. So you can see that this is a cribriform variant, and you can see that this picture is almost the same. It is almost the same as I've shown you in ADH. But then what is the difference? Difference lies in the criteria, and therefore we need to see all the spaces very carefully. We need to see the size very carefully. Okay. So now let's talk about these things in detail. I have just told you all the important points before starting this chapter. So if you talk about the non-proliferative breast changes, the first point is that this is the fibrocystic disease. Under the non-proliferative breast changes, you have the mild hyperplasia, which I told you, which is the usual ductal hyperplasia. You have the duct ectasia, then apocrine metaplasia, adenosis, fibroadenoma without complex features. All these things you have to remember by heart. And proliferative disease without atypia, it is the moderate or florid hyperplasia, sclerosing adenosis, complex sclerosing lesion, fibroadenoma with complex features, and this I've already mentioned, and of course the carcinoma in situ. So now if I talk about the individual lesions in detail, if you talk about the fibrocystic changes, I have mentioned these points in the earlier video in which I have talked about the importance, or rather the controversies that is there regarding self breast examination, and what I personally feel and what I personally have learned through my experience and my knowledge. And there I mentioned all these points, that fibrocystic disease is basically a lumpy bumpy breast where you see multiple small lumps all over the breast, and these lumps are not mobile as in case of fibroadenoma. These lumps are fixed at one place only, and their size changes with the menstrual cycle, and the pain also sometimes varies with respect to menstrual cycle. So patients presents mass of variable size that may be ill defined, and this is a non-proliferative, and it is basically a lumpy bumpy breast. It is basically a benign condition, so there is nothing much to worry about this. Next are the cystic changes with apocrine metaplasia. Then we have fibrosis. Next we have adenosis. All these definitions you must know. What is adenosis? Adenosis is defined as an increase in the number of acini per lobule. Very important definition. The acini are lined by columnar cells, and calcifications may be occasionally present. Lactational adenoma is present in the pregnant or lactating women, and they regress after the cessation of lactational changes. What about the flat epithelial atypia? It is a clonal process characterized by the presence of a dilated acini and cysts which are lined by epithelial cells that display mild cytological atypia. It is associated with the deletions of chromosome 16, and it is the earliest morphologically recognizable clonal lesion of the breast. Very, very important. This is just the definition. You have to kind of know this, that the flat epithelial atypia is associated with lesions that increase the risk of cancer. So flat epithelial atypia is basically associated with increase in the risk of cancer, which means it is associated with the atypical hyperplasia. Just now I mentioned about this. Therefore, you must know this definition, and this point is important. Now, proliferative breast disease without atypia, I've already mentioned that this proliferation of the epithelial cells, but then they are without atypia, and therefore they're associated with a small increase in the risk of a subsequent carcinoma. So these are basically predictors of risk, right? So here I can just tell you this point, that if you talk about this without atypia, means they are predictors of risk of converting to carcinoma, and these are predictors of carcinoma, right? These are predictors of carcinoma. So without atypia wale kya hai? They are predictors of risk, but with atypia wale kya hai? They are predictors of carcinoma or carcinoma in situ, right? And carcinoma in situ is a predictor of invasive carcinoma, right? So you just have to go through these definitions. Epithelial hyperplasia में क्या हो रहा है कि there is a double layer of myoepithelial cell and luminal cell. Now one more thing I just want to mention over here, that if you talk about the myoepithelial cell, like the breast has got this myoepithelial cell and the breast has the luminal cell. These are the two kinds of cell that the breast is having, right? Myoepithelial and luminal. If I can just show you this image, you can see that this is a normal duct, right? And they have a singly basally located myoepithelial layer. So this is the basically the myoepithelial layer. You can see the outer layer is basically the myoepithelial layer. You can see how these cells are present. These are the basal cells. They have a dark compact nuclei. You can see here dark compact nuclei, and they have scant cytoplasm, and they have a single luminal layer, right? And they have a scant cytoplasm, and this inside layer, this is basically the luminal layer. This cell have open a large nuclei, small nucleoli. So you can see that this is the luminal cell. So you have a small nucleoli, right? You can see this is a small nucleoli, and these are large cells compared to the basal cells. You can see basal cells are small, they have dark nuclei, and they are very scant cytoplasm, and these cells are comparatively larger, and they have a nucleoli, they have a more amount of cytoplasm. So these are the two kinds of cells that is present in a normal, acini in the breast. Now this is the diagram of epithelial hyperplasia. So you can see that in this diagram both kind of cell is proliferating, right? So the lumen is filled with a heterogeneous mixed population of luminal and myoepithelial cells. So you can see that both the kind of cells are proliferating over here, and this is what is called as the epithelial hyperplasia. Okay, and this is again of two types. You have the usual one and you have the atypical one, which has a more risk of getting converted into carcinoma in situ. Now the point I'm trying to make you understand here is that these myoepithelial cells, if you talk about the myoepithelial cells, then if these cells are intact or if these cells are present, that will indicate a benign lesion. Okay, most of the times. Okay, there are some exceptions, but then you must remember this dictum. And if these cells are not present, if these cells are absent, then they will be, it is basically a malignant lesion. Okay, so in the malignant lesion, the myoepithelial cell layer that you can see here is lost. Okay, and this is what we see in the microscope ki myoepithelial layer hai ya nahi hai. That is the basis of differentiating this kind of lesions, benign or malignant. So very, very important. And sometimes we don't understand it under the microscope. So what we do is that we do IHC to detect this myoepithelial cell. So for myoepithelial cells, like we have a P63, we have calponin, and all sorts of there are various other myoepithelial markers. We do IHC to detect that whether the cells are present. If they are present, or rather if they are focally present also, then also some kind of benign entity is going on, or if they're completely absent, then that will point towards malignancy. So this is how we kind of diagnose these lesions. So I've told you a lot about the basics and the important points. And now just coming back to this portion, that what is a sclerosing adenosis? Here you can see this is the image of a sclerosing adenosis. The involved TDLU is enlarged, the acini are compressed and distorted by dense stroma, and sometimes calcifications are also present. Talking about the complex sclerosing lesions, they have components of sclerosing adenosis, papilloma, and epithelial hyperplasia. So they have components of all these things, and therefore they are called as complex sclerosing lesions because they combine a lot of other entities, and you have something called as a radial scar. Very, very important MCQ point. What is papilloma? Papilloma is they grow within a dilated duct and are composed of multiple branching fibrovascular core. Epithelial hyperplasia and apocrine metaplasia are frequently present. Large duct papillomas are situated in the lactiferous sinuses. So serous discharge basically results from the intermittent blockage and release of normal breast secretions, but basically these discharge that is happening in case of duct papilloma is bloody, okay, due to torsion of the stalk leading to infarction. So very important, duct papilloma में nipple discharge तो होता है, that is the color of that is bloody. So basically you can see that this is the image of a complex sclerosing lesions, and this is the image of the intraductal papilloma. You have the fibrovascular core extending from the wall of the duct, how they're arborizing in a networking pattern within the lumen and are lined by myoepithelial cells. So because they are lined by myoepithelial cells, you can see this layer is intact, and if they are intact, what I've just said is that, and that is the reason why we can say that these lesions are benign, right? I've told you this just now. Now coming to this atypia valley section, yes, atypical hyperplasia is a clonal proliferation having some but not all of the histological features of carcinoma in situ, and I've already mentioned the important points regarding this. You can see here that atypical ductal hyperplasia is recognized by its resemblance to DCIS. Yes, it has got a resemblance to DCIS because it progresses ultimately to DCIS. It is distinguished from DCIS is that it only partially fills the involved ducts, and what is the size I mentioned? It is less than equal to 2 millimeter, right? Now again the same thing, atypical lobular hyperplasia, it consists of cells which are identical to those of lobular carcinoma in situ, but the cells do not fill or distant more than 50% of the acini within the lobule. So the same criteria applies over here as well. This point is important, that atypical ductal hyperplasia and atypical lobular hyperplasia express high levels of estrogen receptor. They have a low rate of proliferation, and they may have acquired chromosomal aberrations such as losses of 16q and 17p or gain of 1q. Very, very important question. So we are done with this, and now the next topic is going to be carcinoma of the breast.